We are in good shape. We have one missing, right?
David is going to be joining online, yes.
Okay, but he should be joining online soon.
Yeah.
Okay, it is 2 minutes past 2. We're going to call the Oversight Council to order. Before we begin, though, I want to welcome someone and I want to say goodbye to somebody. So welcome. He's on the screen, Alan Sager. He's the professor of health law, policy, and management at BU School of Public Health. We welcome you. We are looking forward to working with you, and it should be great fun. So thank you. And then we say sad goodbye to Cassandra, who is leaving us amazingly and from A&F and going to take a position at Mass Health. This is your last council meeting.
Yes.
I know. What is it you're going to do at Mass Health?
So I'm joining their eligibility policy group. The position is Director of Eligibility Regulatory Compliance. As everyone here is familiar with, the federal rules and regs that dictate all things Mass Health, including eligibility, are constantly changing. And so in this position, I will be helping them understand what those changes look like and mean, and how to comply, what their options look like, what they have to do, what they can do, and then helping implement those eligibility rules through regulations at the state level, even dealing with appeals when people are denied eligibility, things like that. So I think it'll be a really exciting position. Get to really dive in and become a subject matter expert in ways that I sometimes sort of get to dabble in at A&F, but haven't really been able to fully do. So it's an exciting move for me. And as far as the time I've spent here with CHIA, I just want to thank everybody. It's been a great experience working with Ray's team previously and with Lauren's team. It's always a pleasure to come over or to log in virtually and learn about the very impressive work that's happening here. And from the A&F perspective, to kind of work behind the scenes to make sure that the team here is supported financially the way that they need to be, whether that's through capital investments, through operating budget planning. It's a real pleasure, and it has been, to collaborate with the group here. It was fabulous under Ray's leadership, and it's just been awesome to see Lauren take over and keep running with the good work that's done here. So thank you for letting me be a part of it and participating here on the council. I've really enjoyed it, and hope our paths will continue to cross.
Thank you for being a terrific council member, and thank you for staying involved in the crazy healthcare system in Massachusetts. We will probably run into each other again, which is terrific. Next item is the minutes. Can I have a motion?
So moved.
Thank you. A second?
Second.
Okay. We'll move into, if there is any discussion, for those of you who may not have been at the last meeting, under Robert's rules, you are allowed to participate in any discussion. You are also allowed to vote yes, which I find fascinating, but you can also abstain. So is there any conversation, discussion, addition to the minutes? Hearing none, because we have people outside of the room, we are going to have to do a roll call. So when I call your name, please say aye or nay. Brett.
Aye.
David is not here. Adriana.
Aye.
Thank you. Niels.
Aye.
Thank you. Thank you. I'm impressed that you were able to, not go on mute. Cassandra, you're last. Aye. Wonderful. Alan, welcome.
Thank you. I should abstain.
Okay. Karen. Aye. Sandra. Aye. And Jean. Aye. Great. So moved. Before I turn it over to you, Lauren, I guess I want to sort of remind everybody on the role of the Oversight Council. It's actually pretty prescribed by legislation. See, we are the repository of health information, and we are the source for policymakers, for researchers, for legislators of information. And having worked in other states, this is really great here. It really makes a difference. And we allow people to do their work with common understanding what the data says. So today we're going to start appropriately with what is probably the heaviest lift of research and reporting for the council, and that is the annual report. which is incredibly good this year. For those of you who haven't read it, do skim it at least. It's very thorough. And it formed the basis for the Health Policy Commission, I think it was, last week. Yeah, last week, at which Lauren and David, who is one of the council members, presented. And I am going to be thrilled to turn it over to you for a more full discussion. But I want to say, I thought A, the report was good, and B, the commission meeting went really well. So like to start on a positive. Okay, it was good.
Thank you. Before we get to the positive, I do want to just touch on the executive, a couple items in the executive director's report, which is, I think, real quick, but as they mentioned, we had the benchmark hearing last week. We also had the Ways and Means budget hearing. So last week was a full pack week with multiple hearings, releasing the annual report, and a few other companion pieces. But just in terms of broader legislative update, so we at CHIA are monitoring a couple of pieces of healthcare legislation. We know from the House and Senate that they both highlighted healthcare as a priority in the last several months of formal session, which will end at the end of July. So we were watching and monitoring that closely, particularly those pieces of legislation that have explicit directives for CHIA. We also have a mandated benefit review, which is for some of the newer council members. CHIA is tasked with conducting a medical efficacy and fiscal impact analysis for any bills, or on behalf of the legislature, for bills that are sent by the respective legislative committees, for any bills that require fully insured commercial plans to cover new benefits. So the current mandated benefit bill that we're reviewing right now would require coverage for biomarker testing, which there is broad interest in this from different perspectives. So that is a mandated benefit analysis, a report that we plan to release and submit to the legislature in sort of early to mid-April. So that's it on the legislative front. On the budget side, as I mentioned, CHIA testified at the Joint Ways and Means hearing last Monday on our FY25 budget request. So still more to come on that. There's still 2 more steps in the process between the budget bill getting taken up by the House and the Senate. So we won't know sort of fully where our number for appropriation lands until July at the earliest. Sometimes it's led into August. But related, CHIA, per statute, CHIA will be holding its own budget hearing on April 16th that we do sort of in conjunction with ANF. So as soon as you all sort of know who will be sitting in for the executive office vehicle, so that we can get that April 16th will be there where we know it. And that really is an opportunity for the public to provide testimony and weigh in on how CHIA should be allocating and spending its resources. I think, again, that's sort of a construct of, given CHIA is an assessed account, appropriation comes from the legislature, that sets the basis for what we're currently assessing on hospitals, ASCs, and payers. But I think this budget hearing, again, where the council is required to hold per statute, allows an opportunity for the public to, and oftentimes it's mostly industry participants, namely the assessees that have in the past provided feedback. And then there's been years that we've had no one testify. So it's really
all the council members are affected that.
Yes, that's correct. So more the information on the April 16th hearing still to come, but that's the general context for it.
Question, is the governor's proposal sort of including significant changes relative to prior year?
Yeah, the governor's budget generally sort of level funds CHIA's operation. So it's something that there's no significant material modifications. All right, and then the last piece of the executive director's report is just to provide an update on the ongoing situation with Steward, given it's hard to sort of open the news these days without seeing something on Steward, and just to share right to the council a brief overview and sort of history as it relates to CHIA and where things stand today. So as many of you are probably familiar, hospitals and health systems by law are required to submit annual audited financial statements to CHIA. This helps to source and inform our provider, all of our rich data on provider financials. Steward has not submitted audited financials statements in full compliance with CHIA's regulations since their 2012 filing. In light of this noncompliance, CHIA subsequently levied fines against Steward for their noncompliance, and in 2017, Steward sued CHIA for those fines. So we've been in protracted litigation since. Steward filed it's gone to appeal. So Steward filed its most recent appeals in February, and CHIA's brief that I think is due at the end of this month. So we continue to work with the Attorney General's office, who's been representing CHIA in this litigation, but wanted to just keep the council apprised because I'm sure that there are a lot of questions, and I know that there's a lot of attention on this issue right now. But that is CHIA's slice of the Steward saga. Any questions?
Now you can turn it over to the board.
Yes, thank you. Yes, more positive news. So as mentioned, CHIA released its annual report last week. And this really does represent CHIA's most cross-cutting publication and represents many months work across almost every business unit and department here at CHIA. The report includes the calculation of the Commonwealth's total healthcare expenditure, the THCE number, as well as its performance against the cost growth benchmark, which is set annually by HPC. The report also includes and examines other trends, cost, utilization, coverage, quality, and I think is used as a source of truth, if you will, and provides that comprehensive snapshot of what's happening in the market. And this year's annual report was essentially data through 2022, and there are some exceptions to that, but generally it looked at performance of the healthcare system from 21 to 22. So my colleague Molly will go through and highlight a few of the key findings from the report, but want to just note that the slides do not reflect, are by no means exhaustive of all the topics and issues that are covered in the 150-page plus report. And these are the same slides that I presented at the HPC's benchmark hearing last week, which was followed by a robust discussion that other HPC commissioners, legislators, and the individuals that testified, the industry leaders that testified, to really sort of, I would say the theme of the day was around how do we take these numbers in context of the broader challenges that the healthcare industry system is facing right now. I think for some of the new members, we've added a video before we go into some of the key findings from the report. I wanted to share a video that HPC had created, which really outlines the HPC benchmark process to help put the CHIA's annual report into a broader context and process for those that might be less familiar.
And this was shown at the commission meeting?
Yes, this was shown at the HPC benchmark.
I think it's good to see how we're presented.
Yeah.
Especially to others. Agreed.
In 2012, Massachusetts passed into law landmark healthcare reforms, including establishing a first-in-the-nation benchmark or target for a sustainable rate of healthcare cost growth. The Massachusetts Health Policy Commission and the Center for Health Information and Analysis engage in an annual process to measure and monitor spending performance relative to this benchmark. The HPC is responsible for prospectively setting the benchmark for the following calendar year. CHIA is responsible for retrospectively reporting on the Commonwealth's performance against the benchmark. To promote accountability for meeting the benchmark, CHIA can also confidentially refer health plans and providers with excessive spending growth to the HPC for evaluation and the potential implementation of a performance improvement plan to reduce spending growth. Jointly with the state legislature, the HPC convenes an annual public hearing in March to consider data, information, and public testimony to inform the benchmark rate. Following this hearing, the HPC Board of Commissioners must vote to set the benchmark by April 15th. The benchmark is designed as a measurable goal for, not a cap on, healthcare spending, which allows the Commonwealth to track its progress and motivate collective action to moderate healthcare spending growth over time. State law prescribes a default benchmark rate in relation to a projection of the Commonwealth's long-term economic growth and gives the HPC Board increasing discretion to modify the benchmark subject to legislative review. The benchmark was originally set by statute at 3.6% beginning in 2013. It was then lowered automatically to 3.1% in 2018 and rose again to 3.6% in 2023. The Commonwealth examines healthcare spending growth against the benchmark by calculating the change in total healthcare expenditures, or THCE. Growth in THCE was above the benchmark on average from 2017 to 2022, with prescription drugs and hospital outpatient services as the leading drivers of spending growth from private health plans in recent years. THCE is defined as the annual sum of all healthcare expenditures in the Commonwealth from both private and public sources, including Medicare and Medicaid. It is calculated on a per-person basis to control for increases in healthcare spending due to population growth. CHIA calculates THCE using data from the state and federal governments as well as data reported by health plans. CHIA also uses this data to identify and confidentially refer health plans and provider groups with excessive spending growth to the HPC for review and the potential implementation of a performance improvement plan. Now that we know what the benchmark is and how the Commonwealth has performed against it over time, what is the impact on the people of the Commonwealth? When healthcare spending outpaces growth in the overall economy, it produces ripple effects that exacerbate existing affordability challenges like high premiums and deductibles. As deductibles rise, families are at increased risk of medical debt and may forego necessary care. For example, in 2021, 46% of Massachusetts adults who were surveyed reported putting off medical care due to cost. Health outcomes suffer as a result, with widening disparities based on race, ethnicity, income, and other factors. The benchmark is an important tool to help mitigate the trend of rising healthcare costs, and maintaining and strengthening it could result in significant benefits over time. If healthcare spending grew at the target rate of 3.6%, rather than the current trajectory of 5.8%, family premiums and out-of-pocket spending would be 14% lower, with nearly $13,000 more in take-home pay per worker in Massachusetts by year 2030.
So with that context, let me just pause to see if any questions on the bigger picture before we dive into the key findings. Good now? Okay. I'll now turn it over to Molly Bailey, who has been such a sort of one of the leaders and as a conductors of the annual report. I can safely say the annual report would not happen without Molly, but Molly will while it was a team effort, Molly was critical part of that team. If you want to go through the key findings and then we can take questions at the end.
Okay, so first, I'll start with the state's performance against the 2022 benchmark, which was set at 3.1%. So in 2022, overall THC increased to $71.7 billion in Massachusetts, coming to just more than 10,000 per resident and putting the per capita growth rate at 5.8%. So apart from 2021, this represents the highest one-year growth since CHIA started measuring in 2012. When we look at the major payer categories presented on the slide and throughout the report, you'll see that we highlighted the PMPM values, so the per member per month values, in addition to the spending and enrollment trends to adequately capture the pronounced shifts in enrollment during this time period, most specifically to Mass Health. So starting with the largest payer type, spending for private commercial members increased 4.1% on a per member per month basis. This was driven by a 0.7% increase in aggregate spending and a 3.2% decline in enrollment. Mass Health spending increased 1.7% PMPM, driven by 11.1% in spending and a 9.2% increase in enrollment, with the enrollment trends largely driven by federal Medicaid coverage requirements that were in effect through 2022. And then finally, Medicare spending, which includes original Medicare and Medicare Advantage, increased 3.3% PMPM, driven by a 4.1% increase in aggregate spending and a relatively steady 0.8% increase in enrollment. So on the next slide, we take THCE, we break it down by its service category components. So first looking at hospital care, which totaled $25.3 billion, we see divergent trends by setting, with inpatient spending declining 1.4% and outpatient spending increasing 5%. When we combine inpatient and outpatient spending, total hospital care services increased 1.8% in 2022. Pharmacy spending, after accounting for rebates that health plans receive from manufacturers, grew by 8.3% and represented the largest driver of spending growth in 2022. Non-claim spending, which refers to spending growth for healthcare outside of direct payments for specific services, grew 23.3% in 2022. However, this was largely driven by $621.5 million in one-time COVID-19 related supplemental payments Mass Health made to providers pursuant to state and federal legislation. So on the next slide, we'll turn to some healthcare spending trends and how they're experienced by individual consumers and employers. And here we're presenting data on selected healthcare affordability metrics. So from 21 to 2022, monthly premiums in the fully insured commercial market increased 5.8%, averaging out to $595 per member per month. Cost sharing at the point of care, which represents co-payments, co-insurance, and deductibles, increased 6% to an average of $61 per member per month. We also highlight here that 42.4% of members with commercial insurance were enrolled in a high deductible health plan in 2022, which represented deductibles of $1,400 for individuals. And this continued a long-standing trend that has seen enrollment in these plans more than double over the past 10 years. And then also as a result of rising premiums, as a result of rising premiums and cost sharing and high deductible enrollment, a 2021 CHIA survey showed that nearly 1/3 of Massachusetts residents reported that they or a family member went without healthcare services in the past 12 months due to the cost of care. And this trend was especially pronounced among residents identifying Hispanic, Black, or other in multiple races. And then on the final slide, CHIA's annual report also examines trends in utilization and financial performance across a number of provider types. So on this slide, we present some of these measures specific to acute care hospitals. In terms of utilization, the number of acute inpatient hospitalizations declined nearly 10% between 2019 and 2022, while the average length of stay has steadily risen. The increasing lengths of stay can be attributed to throughput challenges such as placement in post-acute care settings, workforce shortages, and shifts in the type and severity of conditions, among other factors. The impact of some of these trends can be seen in CHIA's hospital financial measures. So in hospital fiscal year 2022, the statewide median total margin, which includes both operating and non-operating margins, was negative 4.2%. However, preliminary data through June of 2023 reflects a slight recovery, with total median margins increasing to 1.6%. When we narrow down and look exclusively at operating margins, this trend follows a similar pattern, with statewide median operating margin at a negative 1.3% in hospital fiscal year 2022, and a slight rebound to 0.2% in the data through June of 2023. The takeaway from all these medians and aggregate figures is that while financial performance varied by hospital, the overarching trends were consistent across all hospital cohorts, as hospital cohorts experienced negative median margins in 2022 and saw a slight recovery in their margins through 2023. So as mentioned in the video, the next step for CHIA is to confidentially refer entities to the Health Policy Commission. And that's the end of my portion if there are any questions.
Yep. We take this, yeah, so we can get the people back. Great. So you can rejoin us. You probably can see us, but we can't see you. Terrific, thank you. Thoughts? Questions? How do you divide the, when you look at the numbers between, is it commercial, Medicare, Medicaid? Are they all a third, half?
Commercial is the largest segment, I think, like 30% of spending, and then I think Mass Health and Medicare come in at only 25, 27 each for total THC.
I was thinking of the 100%. I was trying to divide all the money,
The 71.7 billion.
the billions of dollars that are spent.
Yes,
It's half, it's only 30% for commercial, 70% is government.
I'm not entirely sure of the numbers off the top of my head, but there are also two other components of THC that weren't reflected in the slides, which are the net cost of private health insurance and other public programs. But Mass Health and Medicare do make a combined a larger portion of the commercial market.
Yes, okay, that's
Yes.
what I was trying to figure out, thank you. And so as the percentages change in terms of cost, it depends on what the base is.
Yeah, because I think Molly actually alluded to that, because if you look at overall it's 5.8, but all three components are less than 1.5. It just means that most of it is actually because of shift in membership to Mass Health, which has the highest PNP, right?
Yeah, the issue with those numbers not tying is that the 5.8% performance against the benchmark uses census data as the denominator. So it takes the 71.7 billion and source the population from the census. When we look at the different components of Mass Health, Medicare, and commercial, we're using membership exactly. So they're not going to tie 1-to-1. So that's why there's kind of a disconnect between those PMPM values and the performance against the benchmark.
No, I know, but still directionally,
Yeah.
it shouldn't be components are all here, but composite here. It means that there is a shift in mix, right? I think.
Yes, yes. I mean, we saw that is what sort of drove those dynamic, sort of like inverse numbers of spending and enrollment and the PMPM, which is why we sort of elevated the PMPM numbers this year more so than we have in the past, because looking at the insurance sort of segment, the payer segments alone, like looking at commercial spending increasing by 0.7%, that really understates the growth trends because they actually have declines in enrollment.
Right.
Similarly, Mass Health spending looks like it's way above benchmark. Yes, exactly. Yeah. So I think the per member per month figures are the most, I would say, sort of comprehensive and indicative of the trends that we saw in each of those segments during this time period.
Yeah, it's a really excellent report. Thank you for the presentation, Molly, and the work of the broader team, Lauren. As Faye was saying, you know, the good news is that the report itself is so well done. It has advancements in metrics from prior years, just sort of building on the foundation from before to be even more precise and sort of informative. Of course, overall, it's a very sobering story. And so it's bad news in the sense that the facts for us as a Commonwealth in terms of some of the secular trends, we appreciated, you know, we'll be looking to the agency's partnership with your Health Policy Commission counterparts and the infrastructure that the video short described as sort of our collective, you know, Commonwealth-wide mechanism to continue to be proactive around some of the insights that this data provides around affordability, access, and equity.
I see David waiting, and we could just admit him.
Oh, okay.
Likewise, Karen, I just wanted to make sure that our colleague David made it in. Hey, David.
Hey, David, you missed a good conversation on the report that was done, the commission hearing last week. Would you like to add any color? Oh, and the video was terrific, by the way.
Good afternoon, council members, Director Peters. It was a tremendous presentation by CHIA and a lot of really interesting questions from legislators and HPC staff. And I think a great showcase of the work that CHIA does. So nothing more to add. We're very pleased with the event and with the presentation, and more to come.
Because in some ways, I mean, this was really a heavy lift and really hard, but the really hard work is beginning, but we have a great base. Okay, good.
Thank you. Thanks, Molly.
We are going to move to, are you going to tee up the CHIA priority areas, which might be helpful again for a new member?
Yes.
And how we think about the agenda each quarter.
Yes. So for Dr. Sager and some of the newer council members, the way we've tried to approach providing updates and soliciting feedback from the council members on our various priority areas, acknowledging that we can't do deep dives into each and every one of them every meeting. We've tried to sort of hone in on one or two priority areas each meeting, with sort of more brief updates on the other priority areas and initiatives, just so that we can really dedicate time each meeting to one or two of these initiatives. And so this meeting, we're looking to sort of do a review of our planned behavioral health dashboard, and really looking for that deep dive discussion and to hear from all of you as we're still in the development phase of this. You know, what are some of the metrics that we should be considering? What are we missing? Are there other domains that we should be including here on the dashboard? And really, we have teed up a set of discussion questions, but by no means do we need to follow. Just looking for general feedback. And then following the behavioral health dashboard section, we'll go through a couple of the other priority areas that are underway, and we have sort of brief status updates for you. So with that, I will turn it over to Erin Bonnie.
Great, thanks all. Good afternoon. So as Lauren mentioned, as part of our work to expand our work around measuring behavioral health, the team here at CHIA has been working to scope out a behavioral health dashboard. So this would expand on what is included in the annual report and would also complement our existing primary care dashboard. So on this first slide, we have a little bit of background, including our charge from the Mental Health BBC Act around reporting on behavioral health care. So the goal for this dashboard would be to employ similar tenets as what we've done on the primary care side. So using data that is publicly available, is updated regularly, and grouping that data and grouping those measures into domains to give a high level overview of the behavioral health landscape in Massachusetts. So for this behavioral health dashboard, we're proposing 6 domains, including access, finance, quality, and equity. All of those exist on the primary care side. The behavioral health would have 2 additional domains specific to utilization and workforce. So the next couple slides are a lot. I'm going to walk through them pretty quickly. It's the list of all of the proposed measures in the domains. Certainly, please stop if you have questions on any specific measure, but just to give an overview, I'll walk through the next couple slides quickly. So can we go to the next one? Thank you. So similar to the primary care dashboard, we're planning on including a context section that will include some outcomes data points. So the goal of these is really to provide a view of the landscape, and that these measures can also act as a baseline as to where we are in this moment in time. The access measures, that's one of the domains that we're proposing, are looking largely at unmet healthcare needs as well as if providers are accepting Medicaid. On the next slide. So the next two domains are finance and workforce. So the finance measures, as we can see, are sourced primarily from CHIA's primary care and behavioral health data collection that started a few years ago. And it also includes measures that are specific to what percentage of residents are paying for their behavioral health care out of pocket, employers that have waived or reduced cost sharing for mental health and or sub services, and also looking at and measuring spending specific to the Children's Behavioral Health Initiative. And then on workforce, we have a variety of just kind of top level measures to get at, to provide an overview of the types of providers that are providing behavioral health, mental health, and substance use disorder care, including average wages from the Bureau of Labor and Statistics, and a average age, numbers of providers, and things like that. So moving to the next slide. Oh, sorry. So on utilization, long list of measures here, but again, using a variety of CHIA's data assets. And some of these measures are included in the Health Policy Commission's cost trends report. So we'll be referencing that great work as well. And then on the quality domain, so the quality domain is largely sourced from HEDIS, and it leverages the aligned quality measure set. And it also looks at rates of screening and average time spent in emergency departments for mental health visits. And then the last domain that we're proposing is the equity domain, which will take measures that appear elsewhere in the dashboard and stratify them along race and ethnicity as well as geography for whatever measures we can. So I'll pause here if there are any specific questions before we dive into the questions that our team has for you all.
Right now, just sort of note on the last slide when we talked about quality. Yes, we sourced the two primary sources like HEDIS, and then for those that may not be familiar, the aligned measure set is a set of measures that a collective group of public and private stakeholders have joined together to create what is called the UHHS Quality Measure Alignment Task Force, otherwise known as QMAT. And this group's been meeting since 2017 and has aligned on a set of sort of core and menu measures for adoption in global budget contracts, with the goal of administrative simplification, reducing the number of clinical quality measures that payers and providers are using. The second goal is really to help advance those improvement on those quality measures that we at the state and the industry participants, stakeholders have said these are the most important areas for us to align our resources and energy. So I just wanted to give that context with this dense set of quality metrics that give the context of what the aligned measure set means.
And just a clarification on the equity measures.
Yes.
So this slide lays out the elements of the dashboard that would be available to be broken out either by race and ethnicity or geography, is that correct?
Yes.
And for the remaining elements of the dashboard, would there be an ability to drill down, or are those kind of static and statewide?
That's a good question. So it really depends on the specific measure because we're sourcing this from a variety of places. It's going to depend on how rich and how robust and how detailed the data is from where we get it. For metrics that are sourced from CHIA data, we have a little more, we collect it, we have a little leeway. A lot of these come from the Massachusetts Health Insurance Survey. If it's a metric that we're getting from, say, like the CDC, it depends on what the CDC puts out as to what level of detail and what we would be able to do if we could stratify it.
Understood. If the source allowed for kind of additional granularity, is the vision of this dashboard that it would pass that along to the end user in terms of the ability to kind of drill down?
Yes, and so that's actually one of our questions for you. So if there are no other questions.
Just on the questions, because we should move into some
Okay.
discussion here. You've got people who play in this space a lot.
Great, so we're gonna start from the bottom of this list and work our way up. So our initial vision, so similar to the primary care dashboard, which takes a very static form, it's a PDF, it has the domain set. We are interested in doing something similar where you can look at it as a snapshot. In addition, or another option is we could do something more interactive that would have all of that level of detail onto the end user. So one option is we do a PDF very static. Another option is we pass all of the detail we have onto the end user. The third option is we do both, so that there is something that provides that snapshot, high level overview. In addition, for users that want to say, okay, well, actually, this is helpful, but I want to look at this measured by geography, or what is a more detailed view, say, the spending. I want to look at that by payer provider, having that component available to those users.
Jane, you look like you have something.
I would say if the interactive version is the only way to push the actual content out, then I would say we definitely want the information. But you know, if there's a way to, just like the report that we just looked at, 157 pages, I actually looked at it, it was just extraordinary. If there's a way to present that information package at that level as well, I think it's easier for some others. So I guess my question is, by going with the static, do we sacrifice on a level of detail that is available to the public?
Yes, if we went only with the static version, you know, we would be looking at probably a
More summary.
6 or 7 page, summary level. This is the statewide number. If we, in addition, did an interactive component, you would be able to dig into that statewide with whatever stratifications we have available.
So then we said both?
Yeah.
If that's
Sure, go for it.
That is my team's preferred answer as well, so, but wanted to check with you all.
And we put the faces of the people on screen, so if people have questions, we know that they have questions.
Yeah.
Thank you.
Yeah.
There is a question on the screen. I see a hand.
Thank you. I hope you can hear me okay. I'm having a bit of difficulty hearing many speakers owing to a kind of muddiness in the sound. I don't know if anything can be done about that. The video was very clear. The sound on the video was very clear. And David, when you spoke, that was also very clear. So I'm not sure quite what's going on. In any case, on point here, difficulties in access owing to cost, very important factor. What about difficulty in finding someone who takes my insurance, or difficulties pertaining to simple saturation of caregiver time, such that waiting times for appointments are unacceptably long, particularly for some payers?
Yes. So those are both really helpful. So the list that we compiled really represents a lot of everything that we could find in this space. So in terms of additional metrics that should be considered for the first phase or for future iterations, we'll definitely look into these to see like if there's data out there, or how we can, if there isn't data available currently, how we can capture it in future iterations of this.
Or I think I understand also asking questions that may be relevant for the next survey. Did I get that right, Alan? Yes.
Yeah.
I have a few content questions as well. First of all, let me just say, I'm so excited to see this dashboard. Just as someone
to speak up.
actually
That may
works
be
in
one of the
behavioral
problems.
health, it's just a
Yeah.
wonderful, wonderful effort. And I understand this will probably take several years for us to continuously, expand it. But even this is amazing. So thank you so much. So with that, I have a few questions. The first is mental health status, the very first. What do we mean by that?
Yes, so that is from our MHAS, the health insurance survey, and so that is going to reflect the percent of residents that were surveyed that self-rated their mental health status as being fair or poor.
Okay, so it's sort of like a global metric and saying what is the population?
Yeah, so what population of Massachusetts residents are saying that like my mental health is fair or poor?
I see. Okay, I think that's really important. Thank you. So my second question is a little bit related to Professor Singer's question is when I see sort of people who are not receiving mental health because of cost, my reaction is cost is but one of many, many reasons for not accessing care. Besides sort of the capacity side of the limitation, there is also literacy, stigma, and especially when it comes to vulnerable populations, the barrier is so much more than cost. So I think if there's a way for us to credibly measure the level of need and the level of care that is being provided, which may or may not be an actual sort of encounter of service. So we need to be holistic about that. But nevertheless, I think we need to measure, are people getting behavioral health care? Because I think most of us have the recognition that a fraction of the people who need services are actually getting it. The reasons are complex, and I think we need to start there. So I sort of recommend in future, we differentiate between mental health in general and serious mental illness, because these are actually very, very different categories. Because people with SMI, it's a whole different category, because this would mean they have lost the independence of living, their loss of being economically solvent. They introduce a whole host of vulnerability that is not just, making providers available for treatment. So, and I think that is a very significant population. I believe 5% of the adults in this country have SMI. And so that's not trivial. And then I think we need to be able to measure to what extent that their needs are being met and whether we are making progress.
Thank you for that, Linda.
Can I keep going? I have a couple
Yes,
more.
please, keep going. And I'm going to ask other people who've been waiting to, hopefully.
I'll be done. I'll be done.
No, take as long as you want, really. It's very helpful.
No, just a couple more that I was thinking. Just in terms of the workforce, it's a good list, but there's no psychiatrist here. I don't know if there's a particular reason, because psychiatrists is actually a serious area of shortage, particularly like child psychiatrists. I think, our ability to measure that as well. But they're also, more sort of not unique, but just newer, like peer workers. So that's a very important component of the workforce. They're creating miracles out there. So I think our ability just to measure the sufficient sort of representation of that would be important. And also, obviously, behavioral health clinicians and workers, their social competency is very important. So maybe as part of the equity component, we need to measure whether we have enough behavioral health clinicians and providers who have the competency with language and sort of the social knowledge as well. So I think that would be important. My last comment would be, I'm really glad to see in the utilization, there is the usage of CVHCs, but it's only one usage of them by insurance type. But there's so many more things that we would like to be able to measure with the CVHC program, which is new. It's a very ambitious program, as you know. It's very much intended as an alternative to emergency rooms. And it's actually, many, many different components. There is a setting that is similar to the emergency room, but it's in a commercial, or is in a community setting, but it also crisis intervention, even crisis beds. So it's sophisticated capacity. I think we need to be able to measure how well the market is using this, particularly in correlation with what's happening on the ED side. I see so many metrics around ED. I only see one around the CBHC. I think we can probably add something. That's all.
And for those of us who don't know very much about it, what the program is.
Oh, I'm so sorry.
No,
Yes,
no,
yes,
right.
of course. Yes. So Karen and probably some others can really speak to that as well. So this is a very important part of the Commonwealth's behavioral health reform roadmap. It stands for Community Behavioral Health Center. So there are 26 of these centers across the Commonwealth. They function as regional hubs. It's like a firehouse model with 24/7 access. They provide emergency counseling, outpatient treatment, pharmacology, but they're also mobile crisis intervention. So if you have a crisis episode, you can come on site, or you can call the center, they will go to you. But the important thing is de-escalation, emergency evaluation, and then there are also crisis beds. So these are short stay beds for 3 to 5 days. So the intent is a whole host of programs end to end to support sort of real-time emergency, not just emergency, but routine as well, behavioral health access needs, really to mitigate this very significant ED clogging issue. So it's new. It's just over a year plus old. So it's still experimental, which is all the more important that we measure the performance and its usage. The Commonwealth made a huge investment, in this program. It's also connected with the 988 number, which is a hotline that allows people to call, when they are in need for urgent behavioral health services. But very, very ambitious reform efforts, and I think we should measure. Thank you. Yes, thank you. Sorry, I said a lot, but
Yeah. Just on the utilization, a follow-up question is, do you have any more specific thoughts on how we would measure the sort of the utilization or success, I think is the term that you use.
Around the
of
CBHC. Yeah, I think we should look at just the utilization. It's sort of like, we should be able to see the use of CBHC corresponding with the decline in ED visits due to behavioral health services, because it's meant to be a preferable alternative to emergency.
I was gonna ask on the utilization front, it looks like a lot of the outpatient stuff is sort of conditional on this showing up in claims data. Do we have a sense for how much of this care is sought on a self-pay basis that will show up from a payer standpoint? And are we thinking about surveying people about seeking care that is covered by insurance, that isn't covered by insurance? How much are we missing if we're not capturing the self-pay side of care?
Yeah. So I don't know the data point answer to your question, because we haven't seen the data yet of what percentage of residents are saying that they're paying for their care out of pocket. So I don't have a sense of that scope.
We included that in the MHAS. I started to interrupt,
Yes,
but
yes.
we included that in the most recent MHAS. So it is something we are collecting.
Yes, I should see it within the next couple.
That was the thing.
I just haven't seen that data point yet.
Right, I don't think that there's likely to be a great data source to find the actual spending amounts short of surveying folks, so just glad to hear that sort of.
Yeah, so in terms of what percentage of residents are paying for their care entirely out of pocket, that is currently in the MHAS. In terms of these additional questions, it's something we can look to include in future surveys. Agree that using claims-based is missing that section of the population. But again, this is our attempted scoping out year one.
Right. And then similar, not on the same exact front, but also on access and ripping on a comment they made previously, and not understanding the limitations of this particular data set, but in terms of the number of behavioral health providers accepting Medicaid, I think to the extent that we can get more granularity beyond yes, no, as Medicaid patients would be good. What share of their panel is Medicaid patients?
are they accepting new Medicaid patients that they don't have a track record with in the last 2 or 3 years? Because, you know, a provider who has one Medicaid patient on a panel who's been on a panel for 5 years is different from a provider who's seeing 100 new Medicaid patients a year.
From the point of people that are doing research that are on the council or know people who are doing research in this field, do you have any insight into what might be happening or might be helpful? Okay. Keep asking questions.
So one other question that I think touches on, both of your questions. So, you know, we've heard that psychiatrists and child psychologists, child psychiatrists are important. The CBHC is the population that is self-pay. Thinking about the components of the behavioral health system, are there specific, if we can only pick 1 or 2 provider types or 1 or 2 care settings to really hone and focus in on in the first year or 2, are there certain segments, certain provider types that the dashboard should focus on or be sure to include, not miss, in addition to all of the great feedback we've already received? So if there's any other thoughts on components or areas. And then taking, I guess, it's up a level in its turn. Oh,
Yeah, but I think you got David with a question. David.
Hi, yes. First of all, this is great, and this will be a really tremendous asset for the Commonwealth. We use the primary care dashboard all the time at the HPC, and I expect that we and others would use this behavioral health workforce dashboard as well. I wanted to say I've been listening along to all the comments and agree with all of the interesting areas that the other council members mentioned as potential areas of interest to continue to expand on this. I think to your immediate question and perhaps to the question that you had first raised around static versus was interactive is I do think that there are important stratifications that come to mind for me in terms of that. If your proposal was to do both, great, that sounds awesome. But that stratification and interactive dashboard may allow for, and in addition to race and ethnicity and geography, you know, there's maybe different trends that we want to understand between mental health and substance use disorder. Jean had mentioned, you know, mental health versus serious mental health. I think another dynamic that is just of top importance is the increasing mental health crisis among children and teens. And so to the extent that there can be some age stratification as well layered into an interactive dashboard that we can see some of the impacts of these on different populations. And I guess to the workforce question, this was already raised around child psychiatrists, but to the extent that we are able to understand what different providers are treating a pediatric and teen population and how that might be changing or different than an adult population. Understanding this is year 1 and we can do what we can, but just wanted to add that additional point. Thank you.
Yeah, yes, thank you. We do have some measures specific to pediatric and or the young adult population, but that's a really helpful comment on the interactive. Our preference is to do both, so great that you all agree with us on that. So I think my last question for you all is, we've talked about these measures and the provider types in terms of how we group them. So the domains that we're proposing are focusing on access, workforce utilization. Does this feel like the right groupings of measures? Does it seem like we are missing something, or that something should be recombined? We kind of looked and did looked at our primary care work, looked at how these we felt they best related, but would love the input of this group in terms of these kind of 6 high level, these are the areas, these are the focal points.
Go for it, Jean.
No, I think these are the good categories. I do have one last question, if you don't mind.
Mhm.
I may not have an easy answer, just that I recognize the spending or the services provided by state agencies like Department of Child and Family and Department of Mental Health are completely excluded from this. So is there a particular reason? Because they do provide services to the population that is relevant here, right? I understand they're a little bit outside of the traditional sort of scope of health. But is that the right, is that right?
We will look into it. Yeah, it's really helpful feedback.
For those of us who don't know the system, is it a large percentage? Is it just a couple? I mean, I have no idea.
I'm familiar with Department of Mental Health. That's $1 billion of spending on an annual basis. So it's not.
For direct care? Or
Yeah.
care for other people that get reported somewhere else?
No, they provide services. So a part of it is human services, but there's definitely clinical service as well.
Yeah, I was trying to figure out which may be picked up from some other place, some other report, but this was all not reported.
No, I don't think the data
Got it.
from the state agencies are here at all. This is all health. But then maybe that's the answer, is that we only capture the health portion of the activities and the spending, which may be right. But it does raise the question, if we're trying to comprehensively evaluate some of the most complex sort of cohorts of the population, does it make sense for us to try to comprehensively look at the services that they receive and then how well that's working? Yeah, so question.
Yeah, that's a great question.
And I think it's fair, but I think it's for the reasons that you said that they fall a little bit outside of
Yes.
our normal data collection framework. But that does not mean that they don't warrant at least consideration. I think the other thing that we're trying to balance here, and this is something that would sort of flip this question back to the council members, is in an effort to, if, for example, we were to add in all the spending from DCF, DMH, MRC, like a bunch of the different state agencies that are sort of directly paying for or contracting for these types of services versus some form of a payer paying for them. I think we could add it, but it will, one could argue that it could sort of dilute from a focus. I think what we're trying to balance is how much of this dashboard should we be focusing in on. Let's look at sort of one of the key problems or major issues of the day, which is ED boarding times and looking at capacity. And so one of the metrics and to sort of align and be able to monitor and measure Commonwealth investments into the system, into the outpatient side of the world, being able to measure the sort of success and efficacy of the rollout of the roadmap, for example, as it plays out on how does it impact ED boarding rates and times. And so I think that was sort of a key focus of this first iteration of the dashboard. Now, if we were to add in all spending to say, this dashboard will get all state spending in the broadest, using the broadest definition, does that dilute from the focus area, or is it only additive, meaning there's no such thing as too much?
Yeah. Definitely, thank you, Lauren. I definitely feel that for the first iteration, this is very extensive already. I think for future, for all the reasons we talked about, it's a question as we think about it. It certainly runs the risk of sort of dilution or more confusion, which is just not what we want. But there is some relevance that we need to be aware of. For example, one way to reduce inpatient psychiatric admission is actually by increasing community capacity to provide these services long-term outside of the institutional setting. You can see that as a continuum, right? So therefore, if you only focus on inpatient psychiatry, outpatient psychiatry, but leave out the community component, then it's a breakdown. That could paint a picture that could be a little bit skewed. But that's a nuanced point. So I think we should be aware of that. And as we think about sort of continuously expanding, not expanding, but just sort of perfecting it, I think it's a question for us to think about.
And both you raise a good point, and perhaps we should be cognizant of what's sort of doable in the short term. Does it need to be phased in? This is a heavy lift with a lot of data. How much is actually available? When you dig into it, and then say, here's what we will think about as we go forward the next time because you're just starting on this journey.
So everything on the list on these slides, data is currently available.
Okay, that's a good start.
So, and so this might be in terms of next steps of where we envision going from here. So we are hoping to finalize metrics for this year, this first iteration, over the next few weeks. We are going to move right into dashboard design. And hopefully we're going to target a publication sometime this summer. So ambitious, but we're very excited about it. So in terms of, I think there are some additional stratifications, particularly for the interactive dashboard. We'll take all this feedback, backseat if there are additional stratifications for what's already available. If there's data available somewhere on these, we'll grab it, we'll add it in where we can. And if not, we'll look and see what our options are for capturing in the future, whether it's one of our surveys, or if there's someone else nationally that is also doing this work that we can kind of get a little assistance from.
So, okay, David, I saw you had your hand up.
Hi, yes, I just wanted to quickly weigh in on the last conversation around adding in some of the state programs here. I guess I think there's an interest there in having kind of the global view of how people access mental health and substance use disorder care, which could have some value. But I would also say, I think, to me, I'm always kind of thinking about what are the policy solutions or ramifications that would flow from some of these findings. And to me, the policy solutions in the commercial market space and people in private delivery of healthcare are very different than the solutions we may think of for state government run programs and requires kind of going through state budgetary proposals and eligibility programs versus what we expect of our insurance companies and our private healthcare providers. So some level of kind of separation may be appropriate just to help us focus on what are the unique solutions in each area that can help improve access. So I'll leave it at that. I think we recognize that that's not going to be a first year thing anyway. So I'll stop. Thanks.
That's a good point. Thank you, David.
Yeah, good discussion. Others?
Just quickly, I wanted to return to a comment that Karen made, and I was also drawn to the access metric sourced from Borum data on the percent of behavioral health providers accepting Medicaid. I don't know if it's possible, but I think it would be very interesting to include a similar metric for commercial insurance, the percent of behavioral health providers accepting any kind of insurance, as well as, maybe in future years, might suggest exploring with the DOI some of the work that's being done to improve and sort of build out provider directories and information about provider availability. Because I think if this tool could develop in a direction to include metrics like a percent of behavioral health providers with availability for new pediatric patients or for new patients of any age, that would be a incredible resource and a great data point as we think about the health of the behavioral health system.
Yes, I personally have been looking for that number for years of what percentage of populations don't take any insurance, because anecdotally, I think we all have various people that have tried to get a provider and they don't take their insurance, they don't take any insurance. I ended up on vacation with a primary care physician and a behavioral health provider. I had a lot of questions about that. But yeah, so that is really good feedback. We'll take it back, and certainly, yes, we recognize that in a lot of these measures, there are significant portions of the population, whether it's patients or providers, that are just missing due to the current structure of the landscape.
Is there a way to take like the NPI for a provider running up against the APCD and basically see who doesn't show up, which means they're either not accepting insurance or they're only accepting coverage from self-insured commercial plans?
That has come up on the list of possible things for us, like, yes, on the list of like, how could we try to get to that question?
So, wait. Yeah, because so many say yes and then don't.
Right. So I honestly, I haven't worked with the APCD data and enough to know if you have NPIs in there, but you have the NPI for all of the providers that you're interested in checking there.
Yeah, there's a lot more nuance than
Yeah.
I'm able to understand or speak to related to the NPIs and the APCD. But yes, broadly, we're looking, part of this exercise is we're looking at what do we have and can we take two databases, whether it's a provider list from DOI or the insurers of here's our list versus the APCD or wherever, you know, NPIs, master NPIs, like can we bump two things against each other to, in essence, subtract one out of another to try to get at that remainder. So broadly, yes.
For as long, I also don't know enough. I'm just,
Yeah. Thank you.
Yeah. Karen, did you want to say something?
I just wanted to, a couple pieces, just to echo other council members' remarks and just really expressing support and appreciation for, this is already an incredible tour de force, 1.0. You can hear the excitement and appreciation for the kind of snapshot meta, synthesis of multiple sources that this comprehensive dashboard represents. And appreciate everyone's openness to already as we brainstorm 2.0 and, where some of those as still kind of unilluminated areas represent. Would underscore what Sandy mentioned about, as part of 2.0, DOI being a helpful agency since they really hold the regulatory levers over behavioral health parity, which is a requirement, at least on paper. And then to offer and to, thank the CHIA team for working so closely with a number of behavioral health leaders within EOHHS who have been looking closely at CPHCs and other pieces, and happy to serve as a facilitator in kind of connecting to additional agencies and additional, in terms of 2.0 to explore some of these questions. I think, having worked together, Jean, I really appreciate the questions that you're raising about what we're trying to answer and sort of what we need to be able to answer certain types of questions. And I do think that you wouldn't need everything in this dashboard if there are sort of other levels or hierarchies of reporting that are happening around CBHCs. So I think having an opportunity for some of the community partners who are so central to that system, having that advanced window of insight, with CHIA as kind of that broker, that neutral data broker to some of the program evaluation that's fully in development around the CBHCs, and then also considering some of those related questions around, not for all questions, but to David's point, for which kinds of precise questions are we missing part of the denominator if we're not pulling in certain pieces, be it DMH, be it DCO. So happy to do that, Erin.
Okay, thank you. And the staff in the Office of Behavioral Health and Mass Health has been incredibly helpful to us so far. So do you want to make sure that's said?
And Cassandra can bear that message as well to her soon to be colleagues.
Yep. I think you're on for primary care too.
Moving right along, yeah. So if there are no other questions right now on behavioral health, to switch a little bit, I would like to provide a brief update on our primary care dashboard, which I know that we've talked about with you all the past couple meetings, both getting your feedback for this next round that we're working on, as well as just routine updates. So as you all know, we are refreshing the data in the primary care dashboard. It's an existing publication. and similar in scope and content to what we just talked through. So the next release of the dashboard is planned for May of this year. So it will include a few new measures around childhood immunization status, as well as medical school graduates entering primary care. We had data on those two measures previously, but we've been able to get a little bit better data. So looking at primary care physicians that said they were going to go into primary care and are still in primary care a couple years later, rather than I'm graduating tomorrow, I am telling you I'm going to go into primary care. So being able to see how many of them are still practicing in terms of childhood vaccinations, rather than looking at just how many kids at age 2 have had their recommended MMR vaccines. It's how many kids have had this whole suite of the 10 common pediatric vaccines. So being able to add a little more nuance, a little more to measures that already included, but refining and enhancing them a little bit. We also, as part of the publication package for the dashboard this year, are going to have an interactive dashboard. So we will put out the static dashboard, that PDF 5, 6, 7 pages that we did in round 1. Round 2 coming up will include an interactive where you will be able to drill down into a lot of those numbers, primarily in the finance and the equity domains. So that's things you'll be able to look at it by geography, by payer type, and various some socio-demographic dimensions, things like that. So any questions on primary care?
So does anyone who, particularly when you're talking about the interactive component for mental health, have thoughts to give to Erin on primary care? Because is this like a practice run for also doing mental in terms of the interactive?
I think it will be similar, yes.
But we have other interactive dashboards.
Yes.
Yes. I was only thinking about the different types of stratification that one might want in each.
Yes. Okay, so we'll take that feedback from behavioral health and also see, yeah, we can kind of, thank you.
That's it.
Thank you.
Thank you.
Our other two primary areas. Sorry. You're thinking.
Yes. Just real briefly here on the workforce survey, which I believe we spoke about 2 council meetings ago. Just wanted to sort of provide a status update where we are and what you could expect over the next couple of months. So the survey fielding ended at the end of January of this year. The team has been hard at work, sort of cleaning, scrubbing, imputating, and readying the data to release on a public dashboard. The plan is to release them sort of sector by sector, and this is in part because we want to get the data out there. The survey was on a rolling basis, so the nursing facilities, for example, they were the first tranche cohort to be fielded. So we had the results ready earlier, and so we're planning to release sector-specific results for nursing facilities, community health centers, and adult day health providers at the end of this month. So that's the first cohort to go out. We will phase by phase sort of release other sectors throughout the month of April, and then the final step to add to the dashboard is the statewide cross-sector analyses, and this is the analysis to look at, for example, what are the vacancy turnover rates of RNs at nursing facilities versus hospitals or CHCs. It will also give us that ability to look at different racial, ethnic comparisons, looking at different regional variation, again, cross-sector and by cross-occupation. So that statewide analysis is slated to sort of be the final release on the workforce dashboard in late May this year. So this again is our inaugural release of the workforce survey. I think it proved to be far more challenging than I think, as with all things, more challenging than expected. And I think what we've committed to the providers as part of this process is to, as we're developing the survey tool or really looking to potentially make modifications to the survey tool for the next round, really solicit the feedback of provider organizations to say, what of this data is useful? What did you like about the process? What didn't you like about the process? Because we understand that this is administratively burdensome for them to fill out yet another survey. And so we are very mindful of that. We want to work with them to, as we work on survey tool 2.0. But I think we are excited to start releasing this data sector by sector, and then to have that statewide cross-sector analysis. Any questions on this? Any feedback that you like?
Thank you. I just want to say thank you. Very excited to see.
I think there's a question about any feedback that we've received to date. So I think one of the more challenging sectors was physician practices. And Mass Medical Society has been a great partner with us. And I think that what we agreed is, instead of, for the next go around, we should really hone in on primary care physicians versus trying to cover the waterfront of all physician specialists. And I think another lesson learned was thinking about how we get our distribution lists, particularly again on the physician practice side, where it is more just diffuse. There were some large physician practices or organizations that the leadership said, like, we haven't heard about this. And I think the survey tool had gone out to sort of the individual sites, and the secretary picks it up and is like, what is this? Who is CHIA and what is this? And I think that connects. I think that's part of the reason that we got pretty low response rates on the physician services side. So it's feedback like that. We're learning how to, what's the best way to source these distribution lists, who are the right folks to target, who's the audience for these surveys, and then thinking about what's the actual content of the survey. What data are we trying to collect, and how should we be modifying it with the changing healthcare system landscape? Because I'm sure that there will be new questions, even in the next 6 months, about that we should be including in our workforce survey. So we will come back to the council as we are in the development phase of workforce survey tool 2.0. To hear your feedback and get your input on how should we be modifying the survey tool for the next iteration. So the final priority area to cover is around health equity. And at the last meeting, we went through what we're calling our 5-point plan around systematically incorporating an equity lens into all of our work, thinking about new data streams and where we may need to collect new data to help fill and address current voids, really coalescing our work around targeted focus areas so that we are to increase the impact and sort of amplify some of the areas that we at CHIA are focusing on, recognizing that other organizations and sister agencies and other groups are focusing in various facets of health, the health equity broader issue. We want to make sure that CHIA is really focusing where we're putting our publications and our research and analysis, so that we can sort of make the most to optimize impact. Along the same lines, being really intentional and deliberate about communication strategies, thinking about how do we amplify messages, how do we work and engage groups and organizations that maybe we haven't worked with as closely in the past, to really help inform the way that we collect information, how we analyze it, and how we disseminate those communications. And then the last one, sort of related to the last bullet, which is CHIA, just as the state sort of hub for data and healthcare data and analytics, we just as much as any of the other sort of areas and points of our plan, we put a premium on our role in supporting EOHHS, the AG's office, the auditors, the legislature, other sister agencies across state government, as well as other ongoing efforts like the Health Equity Compact and other initiatives that are seeking to address and take on the health equity issue. But I wanted to, in that spirit, CHIA is supporting a lot of the great work that EOHHS is leading around health equity. And so I wanted to provide Karen the opportunity, who is leading this work for EHS, to share a little bit more about EHS's initiative and to help inform and so that we can all think about how can CHIA best support your efforts.
Thanks so much, Lauren and Faye. So just drawing on our conversation from the last quarterly meeting, wanted to provide some of the wage caps for this group and, stand ready as a resource to help dock in where there's particular interests or, very much appreciate that this is a shared community-wide goal. The initiative itself is called Advancing Health Equity in Massachusetts. You can read about it on our website. If you just Google AHEM and EOHHS, we like to say that it's place-based, outcomes anchored, condition specific, and community engaged. We just touched on this a little bit last time, but place-based is recognizing that sort of any serious health equity effort today very much understands that one's own zip code is more correlated with your health outcomes than your own genetic code, and recognizing that sort of devastating reality in the US. And when we think about structures and the social determinants of health and all of the conditions in which we live, work, and play, having such a demonstrable impact on outcomes, on health outcomes. If you want to get serious fast, you really need to be looking at our community in a way that recognizes how sticky outcomes are, and that whether it's a heat map of cardiometabolic outcomes, of SUD mortality and morbidity, maternal mortality. I don't know Chris's mind. Maternal mortality and morbidity, educational outcomes, housing access. You'll see that the same communities in a really devastating way consistently, it's very sticky, tend to be on one side of that graph. So having a place-based approach means over the last 6 months or so, mining every available data set, not continuing to admire the problem, but really leaning on the wealth of data we already have to, in a very factual way, lift up those communities that across that panoply of metrics, consistently in a composite way, rank the highest on this list that you don't want to, be at the top of. And that list is published on the website. And that is a North Star for us in thinking about over 2 years, 5 years, 10 years. If our efforts aren't impacting outcomes in any of those communities, we know we have built our work, in a non-effective way. In terms of condition specific and outcomes anchored, it's really getting at the devastating reality that there are disparities in outcomes, in health outcomes, in almost any area that any major condition that we could talk about. And I just listed a few. And so from the administration perspective, it is almost more important to roll up sleeves and dig in a couple of initial areas than spend even more time, sort of, is it 3, is it 4, is it 2, is it, and the two that are anchoring our initial work, maternal and perinatal health and cardiometabolic outcomes. The latter is the top killer, not just nationally, but also here in Massachusetts. The former is really a recognition of sort of place in a population within the lifespan that I think the data clearly show, especially on a stratified basis from a racial justice lens, we are failing. Our moms and our families. And so this is an opportunity to recognize a lot of the intersectionality as well when you think about the comorbidities between different areas. Another one we could add is SUD and behavioral health and mental health, where in terms of SUD and maternal outcomes or hypertension and maternal outcomes, a lot of this is all interconnected. Outcomes anchored means that it's important to have a balanced dashboard and to be looking at more proximal measures, looking at process measures and access measures, but ultimately anchoring ourselves to outcomes, even though the evidence tells us that certain outcomes can't be, you don't realistically, the needle doesn't move on certain outcomes in 6 months, in 12 months. You still have to have the commitment and the courage to measure that over time and to organize the dashboard around that. So in the maternal space, that's definitely severe maternal mortality and morbidity as one example of a North Star measure. And most importantly, being community engaged and recognizing that across the variety that is the Commonwealth and diversity that is the Commonwealth, that's the specific area of focus within the broad umbrella of maternal health will rightly be different community to community. When we think about social determinants, there are communities in certain regions of the state that may lift up transportation as a higher priority than other regions. And that kind of attention to those rich differences across regions has to be a part of the work. So again, it's a broad and vast charge. Very grateful for both CHIA and the Health Policy Commission's engagement and partnership here, as well as across the different agencies in UHHS, the AG's office, and so many others. Happy to answer any questions and much more to come. The work is ahead of us.
Ask questions. That's helpful. You just hinted at it last meeting, and it's great to have more information. Thank you. Okay, last topic. All right.
Nothing like the EAPCD to bring us home here.
It's just grounded. It's good.
Yes. We've asked my coach to join us. He's our Chief Data Officer here at CHIA. So I wanted to do sort of a quick refresh of what the EAPCD project is. So dating back to 2017, CHIA sought to procure let me step back with the goals. So the origins of the EAPCD project is, given the complexity, how onerous the current all-payer claims database was. CHIA set out on the EAPCD journey with sort of 3 goals in mind. One was increasing accessibility, really so that people, if everyday people like me could go in and ask a question. I don't need to know SQL. I don't need to know how to merge different data tables together. I could go on and say, I want to know, what the increase of semaglutide usage has been and what the cost is, how it varies from the Cape versus in Boston. And it would, I'm just making up that question, but for really around increasing accessibility so that it didn't take a data expert or didn't take sort of a time-intensive amount of time and energy to be able to go in and query the ABCD. So one goal of the project was around accessibility. One was really increasing the analytic capacity, meaning integrating multiple data sets, data tables together to allow for that more multidimensional analysis of looking at spending versus utilization. And then finally, the third goal was around utility. So increasing and expanding the sort of end products that users, whether it's internal CHIA users, whether it's analysts from the HPC or the AGO's office or whoever, allowing sort of an increased and expansive set of options and functionality. So we, in setting out on this journey, it was sort of established that we wanted to outsource for the development of this project and for the ongoing operations. So we, at the time, have contracted with Watson Health, Truven originally did. Watson Health, it's hard to keep track of all the chronology. Amidst the procurement, Watson Health acquired Truven, and I think in 2022, Watson Health was sold off by IBM. So it's been our contractor for this project has evolved over the course of this journey. So I'm happy to, on the next slide, happy to sort of share with the group the good news, which is that we have finally sort of crossed the finish line of the development phase of this. So this was, again, I'll say quite a process in terms of the deliverables and ensuring we had all of the necessary pieces in place. And I would say the hard part of this project was building the data model to allow us to achieve all of those objectives. And it took me a while to sort of wrap my head around what it meant to develop, what the development phase entailed, and what it meant to build a data model that would then allow for the enhanced analytic functionality. And the best analogy that the way that I finally was able to wrap my head around it, to the extent it's helpful for all of you, is thinking about an IKEA. For those of you who've been to an IKEA, it's a very sort of intricate, detailed floor plan. So what IBM did for us, building the data model, was essentially laying out the floor plan, saying this is the kitchen. The kitchen section needs to be next to the living room section, and mapping out how everything should be organized, shelved, the walk, like the throughput process. And that again was sort of what I would say is the hard part of this project. And in addition to building the data models, all of the accompanying documentation. And I think those were sort of the final deliverables that that finally got across the finish line in February. The second sort of phase of the contract was around the operations. So I think our contract with IBM said development, build the data model. And then once you built the data model, you need to essentially keep the lights on, run the operations, essentially run the building that the IKEA store is held within. When we went to go, the contract with IBM expires on March 29th. And so we had been of this year, and we had been in negotiations with them for a renewal of the contract. Now that we've finished development for the ongoing operations, we reached a point in the negotiations where it became very apparent to us that the value of having IBM run that we would be paying a premium for IBM to essentially just host and run the operations of the EAPCD, and at a cost and premium that where the value justification was just not there. So we made the hard decision, and it was not one that was made lightly, to not renew with IBM. And instead, the decision was sort of based on our sort of assessment, and I think that reaching the conclusion that we believe that we can host the EAPCD here in-house internally. And so this is, I'm hoping that Mike, you can speak to sort of what we're doing in terms of planning and why we have that confidence that we can host this in-house, and why we feel like this is sort of right direction for CHIA, to give us the sort of necessary flexibility and, also to avoid paying a premium for really like little to no value.
Can I say one thing?
Yeah.
It's a big deal to reach this point. So that's great.
Yeah, so let me just start by saying that I think Lauren's explanation is perfect in what it is. I will just add that the other thing that we pay IBM for is to restock the shelves every quarter in addition to the layout. So this is a data set that we give all the claims data that we receive from all the payers. We get that data every month. We give that data to IBM and support it. IBM then refreshes the data model with the new claims data that we got and all the accompanying data. They also run a series of methodologies, industry-leading healthcare methodologies on the data for us. So what we built, what they did is they designed this thing, and we bought Truven's expertise on healthcare claims. That's why Truven was the selected vendor. They were a leading organization on using healthcare claims. They work with a lot of states on Medicaid plans. Throughout the project, we had Watson Health purchase them. We had Watson Health get sold. The intellectual property that we were using from Truven is now owned by a company called Meredith. And going forward, whether we were with IBM or with somebody else, we have to actually license the intellectual property with Meredith. And so at this point, IBM actually isn't providing any of the expertise that we originally contracted for. What they're providing us is just refreshing the database every quarter. So that was one of the things we looked at when this started to come up. The costs, as Lauren said, were substantially different than what they were previously. A lot happened in 5 years. We have a pandemic affecting the cost of IT services, chips, and hardware, and all those other things. So there's a lot of reasons why the costs went up, but they went up significantly enough that we really needed to take a look at it. There were some really positive attributes in the system. We like the model. We want to perpetuate the model. We want to continue using it. Health Policy Commission has had some users using it. There are some challenges that we've found in our 5-year journey. One of them is that this quarterly process that they run for us can take 3 to 4 weeks for them to actually update the data, because I think they didn't realize just how much data it is. It's billions of claim lines that we get. And so the system on a quarterly basis can be down as much as 4 weeks. And what that does for our users is it makes it very difficult for them to plan and execute their analysis. And I know in particular the Health Policy Commission has felt that particular issue. And so one of the opportunities that we have in looking at hosting it differently than the way it's currently hosted is completely eliminating that downtime. And it's actually not that complicated for us to do. They are using captive hardware that they purchased specifically to host this solution. In 2024, there are a lot of other ways to do that, and we would use Snowflake in cloud, which is a way a lot of organizations, including EOHHS, just decided to do their data modernization against. It will allow us to perform all that quarterly work on the side while our analysts continue to use the data set. And then we will have one day a quarter that we flip it to the updated version. And that will completely eliminate any downtime that the users have, and they can just count on the system being available to them all the time. That's actually not a very expensive thing for us to do. We discussed doing it with our current vendor. It's going to be very costly to do that because they had to create a physical copy of it and buy hardware for that. So doing it ourselves allows us to eliminate the biggest problem that we have with the solution. I think another issue that we had is the query performance, the actual, I want to know something, how long does it take for the system to return? There was a variety of experiences, and some of them were pretty slow. We worked on with our vendor a lot of ways that we could improve that. I think we squeezed about as much improvement out of the way that they built it that we could. Modern cloud technologies give you the opportunity to kind of scale up and scale over through controls rather than having to buy additional hardware and set it up and support it. So taking the cloud approach that we are looking at will allow us to really push as much performance as our users need. And we can do that dynamically. So there's a lot of benefits to using CHIA's cloud, which is based on Microsoft's Azure cloud. I think the other thing that really occurred to us is that if we wanted to make changes to the system and improve it, a lot has changed in 5 years. There's a lot of things we want to do now that we didn't even know we were going to want to do when we started this. Just thinking about the equity agenda we just heard about, we want to add geospatial data to the claims data. And we want to add the relevant SOGI data that we're starting to collect from the e-health record system. We're also looking at starting to collect relevant SOGI from the payers themselves. In order to get that data and really embed it in the solution, it was going to be a substantial cost with the vendor and time to do that. With the resources that we're going to save by taking it in-house, we'll have a lot more capacity to make those changes a lot faster than we would if we kind of stayed the course. So that's in a nutshell why we're doing it. In terms of our capabilities, CHIA is a data operations organization outside of the analysts that you guys hear from all the time. We collect data from, I think, 10,000 different individuals and 25, 30,000 files per year and host the data sets as large as this. This is actually the only thing we don't host ourselves. So in terms of our capability and our capacity, our team knows how to use biotechnologies to do this. And even the HPC, when they access IBM's hosted solution today, they actually connect in through our environment to do that. And then our environment is what connects to the IBM solution. So switching our state users over to this new platform would be very easy for us. Pause there.
Yeah, it's really good to remind ourselves that we don't spend a lot of time talking about what you're talking about. But if it wasn't going well, we wouldn't spend any time on the things we are talking about. So it is appreciated. I guess I'm going to follow up on the last point you made, which is, so why do you think you guys can do it?
Well, one of the points that I think is important is that we do it already for a lot of other data sets and for the APCD itself. Before it goes to the IBM solution, we actually use it internally for a number of analytics, including our cost trends reports and things. Also, with the advent and costs around Snowflake as a technology, it's fairly inexpensive as compared to what we're doing now, and it doesn't require a lot of personnel to kind of manage and maintain. The cloud resources are designed to scale on their own, so it's actually mostly just a technical problem at this point because we're going to take everything that's already been built from the IBM solution. And this is just what our data operations team does all the time.
That's helpful, thank you.
So, but aside from the data enhancements you talked about, like relevant SOGI and ways you might expand, are there any other ways that this might affect end user experience for outside researchers who use the data? And that's a selfish question.
Yes. So originally, I think Ray had aspirations when we started this that eventually we could grow past just the state agencies into some of our research partners. I think that to date, we've actually only grown as far as the Health Policy Commission. There are still folks that are ready to go, I think, or excited to get going. One thing that we couldn't do with the solution as it sits today is expand too much farther. We built it for a set number of users and capacity. Now, using the cloud technology, we can actually go as horizontally as we need to. I think that there's no reason why an external party couldn't use the solution. It's more of the legal data privacy issues that we have to get through. This is the way CMS is actually just announced that they're moving to. They're actually only going to let people use their data in their enclave, and so I think that there's no technical barriers from that. It's more of a policy legal question that would need to be worked out.
So when you make a successful transition, we can come back and talk about, step 2 and 3.
Yeah.
Big deal. Any other questions? Great, thank you. As usual, we're doing a good job about ending on time. Anything else that you would like to add as executive director?
I think that is it. Other than just say thank you all for your input and feedback today. Really, really helpful as always. And just want to say a special sort of thanks and farewell, but not. I know that our paths will cross again, but just want to thank you for your partnership and being such a good partner to CHIA, both in your sort of as a council member, but also in your support with all our different budget questions and challenges and all the fun problems that we've brought to you over the years. So absolutely, very much appreciate you. Wish you the best.
And I will end with a plea to come in person. Yeah, it's a lovely group. It's really nice to see everybody's faces closer. You can hear better. Come in person next time. I know it's hard. Thank you all.
Will do.
Do I hear a motion to adjourn?
So moved.
Come on. Thank you. That's the easy one. A second, please. Second. Thank you. Bye, guys.